Please admit your colleague in the meeting because I cannot see the screen. This is the first case. So the scenario is this is a 12-year-old boy which is referred to the hospital for evaluation of easy bruising and prolonged bleeding after minor injury. There is no significant past medical history. His parents are consanguineous, and the full blood count shows hemoglobin 135, white cell count of 6, platelet of 45, and this is the this is power 10. So let me see who are there. I'm not sure who is the ever support candidate in this case. So the ever support candidate, can you please take out your pen and paper because you have to write your report and further questions. We'll go to power 50.
Can't see the full screen, Amber.
Hmm?
We can't see the full screen. We're only seeing half of it.
I think it's a full screen.
I can't see it. I'm only seeing half of it.
What about the others?
It's okay.
Because
Full screen, yeah.
Yeah, we can see.
because I'm on two teams.
Ah, right. Okay. Yeah, it's happening now. It's okay. Got it.
Right. This is your power 50. I will move slowly.
It's clearly thrombocytopenia.
Mm-hmm.
There's occasional nuclear RBCs there. Nuclear. There's a giant platelet as well.
So Mark is our biomedical scientist consultant. Thank you, Mark.
Okay.
Because the blood film first goes to the lab. The lab staff usually report on them first.
Yeah. Is there a Howard Jolly body there?
Mm-hmm.
Hypersplenism. Who target cells about?
Right. What is your impression, and would you like to refer this to the hematologist or not?
Yeah, so yeah, definitely refer this. Yeah, I mean it's leukopenia. There's whole jolly bodies here. There's thrombocytopenia. I would not give this out. I would definitely refer this to consultant.
Mhm. Right. Those who are appearing or planning for FRC should answer this question on the paper, please. Take a screenshot and then answer this question. Oh,
Is the coagulation okay?
coagulation is okay.
LFT or
They are fine.
okay.
So now I need someone online to report this blood count.
Red cell.
Yeah.
Hello.
Okay.
Hiya. Yeah. So
Sahla.
there is a Sahla. Yeah. There is macrothrombocytopenia with some gain platelets, some target cells in the red cell, and there is no major abnormality in the white blood cells.
Mhm.
There's no. It's quite noticeable. There's no lymphocytes about. No eosinophils, basophils.
Mhm.
A nuclear RBC there.
I don't think I've seen any nucleated red cell.
There's a giant platelet there.
I
You can
think
see
it's
it.
The big platelet.
Yeah.
and Howell-Jolly bodies, I think.
Yeah. So this is not the complete report. I'm expecting a complete report from. Because if you do not give complete report, the person who have seen this patient, they will call you, okay, doctor, you have seen the blood film.
Your advice, okay.
Okay. What is your impression? What should we do next? So
All right.
report the blood.
Yeah, I mean there is suggestive features to suggest hyposplenism
Mhm.
and significant macrothrombocytopenia.
Mhm.
Possible causes immune thrombocytopenia versus hereditary macrothrombocytopenia, given the long history of Bruce.
These are your further questions. Your differential diagnosis, further investigation, and what info you would like to deliver. Patient or parent. You have only 9 minutes in the exam.
Yeah, differential diagnosis, immune hereditary thrombocytopenia, macrothrombocytopenia, example Bernard Soler, gray platelet syndrome, type 2B, von Willebrand.
Mhm.
And second differential is the immune thrombocytopenia. I would say unlikely given the prolonged history.
Mhm.
And I think meheglin as well can cause macrothrombocytopenia.
Yeah. What further tests you would like to do?
We have done the blood film and coagulation screen. Yeah, I would want to do a coagulation screen, renal function and liver function test. Coagulation screen, I mean, looking for if there is any prolongation in the bleeding APTT, it might suggest a von Willebrand disease. And then I will do PFA, platelet light transmission aggregometry.
Your 9 minutes is over. Okay. And you are spending more minutes on this question. You will lose your time in morphology in the part 2. All right. In blood film reporting for the part 2 exam, you need to comment on the abnormality which is prominent in the blood film, which are the big platelets, okay, giant thrombocytopenia in this patient, and then other components. This patient, the blood film shows giant thrombocytopenia. The patient has thrombocytopenia and there are giant platelets as well. Red cell shows whole jolly bodies and target cells, and the white cells are open. Most likely impression is macrothrombocytopenia, which needs further evaluation, further testing to find out whether it is inherited or acquired. And the second question was differential diagnosis. You have mentioned inherited causes, Bernard-Soulier syndrome, Hagelin, gray platelet, etc. The acquired one, which is less likely, I fear. Then the other question was further investigations, because we are suspecting a platelet disorder here, and we have informed you that coagulation screen is normal. But if it is not given, you can say I will do coagulation screen to exclude prolonged APTT, 1 mg screen for type 2 platelet type 1 mg disease, platelet function test, which include light transmission aggregometry for Bernard-Soulier disease, the flow cytometry for the glycoprotein, and genetic testing. Then what information you would like to give to your parent, to the parent? You will explain the results of available investigation to the parent that we are suspecting inherited disorder likely. This patient needs to be transferred to a tertiary center for further testing, and if diagnosis is confirmed, then genetic counseling as well. You have only 9 minutes for 2 short questions. Yes, this is easy. If someone come out from the exam center, he will say, first case was macrothrombocytopaenia. It was an easy case, and the result comes fail. Why? This question does not ask you what is this slide about. There are 6 other marks as well. Because of it, people fail. People fail part 2 exam by 0.5 marks as well. If you were there in the last part 2 session, in which we discussed the people result, we have shown you the result of the people where people fail by 0.5 marks. It is not only about the slides. Slides are very easy. You see the slide of macrothrombocytopenia, CLL, follicular. They do not only ask you the diagnosis. There are 10 marks. You need to answer all the questions. Okay, so this was first slide.
There's red cell agglutination there.
I don't want to show you red cell agglutination. I want to show you something else.
All right.
Oh. The scenario about this patient. For two candidates, please write your answer on the paper. A 6-month-old boy of African descent is referred for evaluation of chronic anemia and failure to thrive. He required a blood transfusion at 3 months of age for symptomatic anemia. No family history of hereditary anemia. The patient has hepatosplenic. HV is 98. Most likely he has recent transfusion. MCV 68. MCT 360. Etc. White cell and platelet counts are normal. The first question is report the blood film, most likely diagnosis, differential diagnosis, and further investigation. Right? Take the screenshot, and then you will go to this is power 10. And let's go to power 50.
Okay. A lot of spherocytes about.
Mm-hmm.
Monocytosis. This could be a
Mm-hmm.
case of autoimmune hemolytic anemia,
Mm-hmm.
possibly HS. Can't see any nuclear RBCs.
And I will go through the blood film if there is any.
Microspherocytes. Neutropenia.
Right. Would you like to refer this to them?
Oh yeah, definitely refer this to consultant. Yeah.
And
Yeah.
your thought is that this is
I think it's probably like autoimmune hemolytic anemia, or possibly a HS. Yeah,
Oh.
autoimmune probably. There's a lot of anocytosis there. A lot of spherocytes. I don't know, there's a toxic granulation in the neutrophils, perhaps as well.
Yeah. Right. So this blood film has been referred by lab staff to clinical hematologists. Please report the blood film and answer the question. Okay, which you have taken the snapshot already. Those who are appearing in part 2 should write their answers on a paper in 6 minutes. So, who want to answer this question?
Can I attempt?
Yes, go ahead, please.
Yeah, this is peripheral blood smear, has significant anemia, and there is marked anisocytosis, poikilocytes. There is polychromasia. These are the red cell abnormalities. Platelets looks adequate. White blood cells or neutrophils look normal with some granules, full of granules.
Hmm.
So, and some red cells with Howell jelly bodies.
Mhm.
So, elliptocytes, ovelocytes, can see some spirocytes. So, my impression is most likely some picolocytosis, hereditary anemia, considering he is requiring blood transfusions since age of 3. So some or hemoglobinopathy. There are no target cells, so I cannot say thalassemia or and there are no sickle cells, so it doesn't look like sickle cell. So it may be some membrane-related diseases of RBC. So that is my differential. Test I would like to do is EMA binding test
Mhm.
and
Genetic testing as well.
yeah, genetic testing also.
Because if you are suspecting hereditary spherocytosis, you confirm this on genetic test. And the differential diagnosis.
Differential diagnosis, hereditary spherocytosis, picolocytosis. There are no stomatocytes, not many. Or you can say ovelocytosis. These all membrane-related issues, diseases.
So mention few non-immune causes of hemolysis, like red cell membranopathy, enzymopathies, and mention 1 or 2 immune-related causes of hemolysis, like autoimmune hemolytic. They are your differential. It's not
Okay.
your top differential. This is just your differential. So this boy has hereditary pyropokilocytosis. The blood film shows all sorts of red cell morphology and sizes. There are macrocytes, there are spherocytes, there are even teardrop cells as well. Yeah, histiocytes are there. And we saw also the whole jelly body as well, because the patient has splenomegaly, so hypofunctioning, clinic hypofunctioning will be there as well. This is a case of uh, hereditary pyropokilocytosis. You're not required to say this is hereditary pyropokilocytosis. You can say most likely this is a hereditary pyropokilocytosis because I need to confirm this on further investigation. You can't make any diagnosis on a blood film. You need further testing, additional testing to confirm your diagnosis. But you have to tell them what is your most likely diagnosis, your most likely impression.
Can I ask question, Jasamir, for
Yeah.
the last case? The reticulocyte counts is 10% only. So do we expect that the reticulocyte to be high?
If the hemolysis is going on in this patient, there were a lot of spherocytes in this case
Mm-hmm.
and macrocytes, the nears. The neutrophil contain a lot of granules. There may be some infection-induced hemolysis going on.
Okay.
That's why the reticulocytes come.
Yeah, sure. Thanks.
And
So
if it is
EM,
and if there is a viral infection, then you will see retic count low because the viruses suppress the retic.
Yes. Yeah.
Yes, Naveed, you are saying something. I made these scenarios for the first time because we have a new batch of FRC part 2 candidates. And we will have a session regarding FRC part 2, planning FRC part 2 on 1st of June. We will discuss something over there as well. But these are the you have a slide in the exam and you have scenario like this with further questions. Okay. This is the slide number 3. 72-year-old man with routine blood test showing high white cell count. He is asymptomatic.
you are
Hemoglobin.
muted.
You cannot hear me?
Now we
Yes,
can.
yeah.
Yes, the connection lost, but now okay.
So hemoglobin is 130, white cell count is 65. This is the platelet count. They're asking you report the blood film, differential diagnosis, further investigation, and indication of treatment and treatment options. So let's see the blood film. This is power 10. And this is power 50. Mark, I have a question for you.
Yeah.
This blood film is 3 months old, but you can see the nuclei
Yeah.
in this. Like something is eating these nuclei. What is the reason of this? Like I have another blood film slide as well.
Yeah.
And when I see the white cell in them, the white cell appear like moth eaten. Like
They're crushed, aren't they, a bit?
no, they were okay previously. With passage of time, the nuclear material disappeared. I don't know what.
Yeah. It's like they're going to smear cells, some of them. You can't find them in infants like that, but yeah, I know what you mean. It's quite unusual. They're not solid, are they? They're not solid. They don't look solid. They just look mashed up.
Yes. Right. So you have seen the scenario. To bring it again to you.
Yeah, it's lymphocytosis.
Okay. And white cell count is 65.
Very high.
What do you think?
So what was the age again? Sorry.
65.
65. Yeah. Was a possible
Age is
CLL?
72.
You know, it could be. It's probably CLL.
Age is 72, and the white cell count is 65.
Yeah. I would say this is probably a CLL. It's the right age for it. The cells look a bit mashed. There's one or two like smear cells there. The reds are okay. Platelets are fine. But yeah, I can see what you mean. They're not. You'd expect like small mature lymphocytes, perhaps more defined cells.
So let's ask the clinical hematologist then
Yeah.
what they think. Rabia.
Yeah. Oh, sorry.
Yes. Yeah. So there is a population of white cell with they are polymorphic with mature clumped chromatin. They looks high in number, but I can see the skirting around the red cells as well. All of them almost like yeah, trying to find smear cells. There are smear cells is scattered. Mm.
Go on with your report.
Yeah, so neutrophils looks mature, well granulated. Platelets looks adequate in number, and red cells looks normal in morphology. So definitely, I will send.
What is your impression before
Um,
sending?
yeah, impression with the smear cells. It could be CLL, but yeah, I think this is could be the first impression.
Better to say
Mm,
most likely impression is
most
lymphoproliferative disorder.
disorder. Okay.
It can be CLL, it can be CD5 negative LPD, it can be something else.
Yes. So most likely impression could it's LPD for further investigations.
What further investigation you would do?
I will send the sample, the peripheral blood for flow cytometry. And then accordingly we can take it forward. But we need to know what is the immunophenotyping.
Immunophenotyping is CD19 positive, 20 positive, 23 positive, and 200 is positive.
Do we have CD5?
CD5 is positive.
So it goes with CLL. Yeah. Yes.
Right. And the next question was
Okay.
indication of treatment and treatment option.
So indication of treatment will be if the patient develops cytopenias or if he has doubling time of the lymphocytes less than 6 months, and if he has symptomatic organomegaly or B symptoms. This is what I can remember so far. So, and option of treatment, usually we discuss with the patient the options that if he want to go for oral for long life, like acalabrutinib or ibrutinib, or if you want to have like a short course of 12 months of obinutuzumab, venetoclax, but also we need to send for the TP53 and IGHB mutations. This can guide us further about the management as well.
So treatment options, you have either fixed duration therapy or
12 months, yeah.
or continuous therapy?
Yeah.
The fixed duration you have mentioned, that there is when O.
Yeah.
The continuous therapy you have mentioned, the BTK inhibitor, the acalabrutinib or zanubrutinib.
Yeah.
When O and when I are fixed duration, and the single agent BTK inhibitor or the continuous one, it depends on patient fitness as well. If the
Yes.
patient is fit, you can give them venetoclax based therapy because it is an intensive treatment. If the patient
Yes.
is not fit, then you have to suggest BTKI. So you have to divide your answer like that. It depends on patient fitness. If the patient is fit, fixed duration. If the patient is unfit, then single agent continuous chemotherapy. Right?
I have a question. Why we are saying that the nucleus is mature? So how should we differentiate?
The mature nucleus, they appear very, very dark. They are dark blue in color. While the immature nucleus, we can see nuclei in them. In myeloid cases, the nucleus is pinkish in color with prominent nuclei in it. In lymphoid cases, the nucleus is bluish in color, light bluish in color with prominent nuclei in it. But if the nucleus is mature, it is very dark blue in color. You cannot see anything inside the nucleus.
So in this case, it was mature or immature?
This was mature.
Mature. Okay.
Yeah.
Okay.
All
Thank
of
you.
them had very dark nucleus, and you were not able to see anything inside it.
Okay. Thank you, sir. Thank you.
Dr. Aman, excuse me, Assalamu alaikum.
Or,
Dr.
yes,
Ahmed, do patients require treatment at this stage? Is you said that patient is asymptomatic and only lymphocytosis on the CTC count. And the history mentioned no lymphadenopathy and no organomegaly, even no base symptoms.
mhm.
So only watch and wakeful uh, strategy for this patient is
For this
mentioned
particular patient, yes.
for this particular patient.
For this particular patient, yes, because he was asymptomatic. The scenario was mentioning to you that the patient is asymptomatic.
Hmm. So the staging, according to the staging, dry and venic stage. So this is a 0 and 1. So we have to monitor this patient, and
Yes.
if there's one, so I think no treatment.
This
Regular.
patient would need monitoring only. If any indication of treatment appeared, as the candidate mentioned, like cytopenias, autoimmune hemolytic anemia, massive splenomegaly, massive lymphadenopathy, pleural effusion, etc., constitutional symptoms, then you will consider this patient for treatment.
Okay.
So the CLL, it has specific indication of treatment. Low-grade lymphoma, they have indications of treatment. You do not treat them all. If someone has follicular lymphoma, not causing any problem, you do not treat. But if someone has DLBCL, then yes, you treat them. Similarly, in hairy cell leukemia and LPD, in the CLL, if the patient has diagnosis but asymptomatic, we do not treat. We just monitor them.
Thank you.
This is 19-year-old boy admitted with intracranial bleed. And the white cell count is 600. I don't have a scenario for that. I was able to make 3 scenarios only. This is power 10. Mark, you think that this is
Looks a bit lymphoid, but looks possibly, yeah. I can see clear nucleoli. Probably
yeah.
looks thrombocytopenia, lymphoblasts.
So Naveed, these are immature cells. You can
Yeah.
see the nucleoli, prominent nucleoli in them,
Mm,
and the nuclear material is very thin.
yeah, and it fills there's a high NC ratio.
Mhm.
The nucleus basically fills the whole cell.
Mhm.
Yeah.
Nucleoli can be present in reactive lymphocyte as well. If you see the nucleoli of infectious mononucleosis, they may have prominent nucleoli as well. Nucleoli may be present in pro-lymphocyte as well, because in CLL you have some population of pro-lymphocytes as well, but their nuclear thickness is different than these.
Mm,
That ability to differentiate between such type of cells will come with passage of time when you see more and more blood film.
yeah.
So this one. So what do you think, Mark?
I think it's an acute lymphoblastic leukemia, an ALL.
Oh,
Definitely needs cell markers. Probably an L1.
right.
Neutropenia.
So let's ask our clinical hematologists what they think.
Well, I think there's a few like cerebral or clover-shaped ones there as well. A little bit,
Mhm.
but no, it's more lymphoblast.
Yeah. So Azza want to report this vaccine. So let's see what Azza says.
Okay, yeah. So there is leukocytosis with mainly increase in mononuclear cell, likely blast, medium to large cells with open chromatin, minimal cytoplasm. Souls have got a bit of basophilic cytoplasm, agranular, and I can see couples of with nucleoli as well of the cells.
Mhm.
Yeah, so red cells, I can't see like many red cells, but slightly
This
anemic.
patient
Mhm.
hemoglobin is 98 and
Yeah.
platelet count is 40.
Yeah. So anemic and thrombocytopenia. Impression is likely acute leukemia, but we'll need further investigation to confirm. Likely ALL, but we'll need further investigation to confirm flow cytometry.
Okay, so you would like to do flow cytometry for this patient.
Yeah.
Flow cytometry is telling you that CD19 is positive, CD2 is negative, CD10 is positive,
Yeah.
and CD3 is positive.
Yeah. So it goes with BALL.
Mhm. Why this patient has hemorrhage?
Yeah. So it's probably as feature of hyperviscosity, maybe.
1 Willebrand disease only.
Hyperviscosity.
1 Willebrand. Thrombocytopenia.
Thrombocytopenia. It's
One
acquired von Willebrand disease, not von
acquired.
Willebrand.
Yeah, acquired.
Right.
Right.
Is
disseminated intravascular coagulation, DIC.
DIC can be there as well. Because this can be one of your first part question, why this patient has bleeding complication.
Okay.
What are the prognostic factors in this patient?
Right. So you mentioned like his age is 19 years old, so this is good prognostic sign, as usually the age is more than, I think, 50 or 40.
Higher
This is
the age,
highest feature.
higher the age, poor the prognosis. More than 40 is considered poor.
Yes.
Hmm.
And I believe also in terms of his white cell count, this is, you mentioned 600, which is again, this is a poor risk feature.
Intracranial bleed. Intracranial bleed itself, poor percentage.
CNS involvement is a poor risk factor. What else?
Patient-related
KMT2.
and disease-related prognostic factors.
Yes. We didn't have it in this scenario now, but like as other features, like Philadelphia chromosome.
Negative. Philadelphia negative.
pH positive is a
He is
poor risk.
positive.
Yeah, pH positive is a poor risk factor.
Yes, so beta rebel positive, this is a poor factor. Sorry, did you say in this scenario is negative or positive?
There is not mentioned in this scenario,
Yeah,
but
not mentioned. Yes.
yes, the question is, what are the prognostic factors? So you would say high
Yeah.
age, high white cell count,
Positive. Yeah.
is the poor prognostic factor. Disease-related factors are the CNS involvement, and then
Yeah.
cytogenetic, BCR-ABL positive, and
Yes.
119, 411 classification is poor prognostic. Hypodiploidy is poor prognostic.
Yeah.
And 1221 is a standard prognostic factor.
Yeah.
Okay. So now, the question is, what urgent intervention would you like to do in this case?
Yeah. For him, because of the very high white cell count, I believe apheresis.
Leukophoresis. Okay.
Leukophoresis. Yeah.
And the neurosurgeon's involvement because he has intracranial bleed,
Yes.
and leukophoresis to bring his count down to double digit.
Yeah.
Oh,
So can I ask, a leukophoresis intracranial bleed is contraindication, isn't it?
no, that is contraindicated in APML
PML only. Okay, yeah, that's fine.
because there the APML patient usually come with DIC and low fibrinogen. Leukophoresis will lead to more hypofibrinogenemia.
All right.
In APML, we do not do leukophoresis. And this patient is going to die from intracranial hemorrhage if we do not reduce the count. Count is 600, and it will eat everything, all the 1 milligram factor in the body. Right, last question. Now the team is planning treatment for this patient. Do you know any treatment protocol to offer to this patient? He is 19-year-old.
19 years old. Yeah, so it is obviously like it would be like, of course, like MDT approach and like the offer clinical trial were available, but it will be like UCAL 14.
UCAL 14, CAL GB.
Yeah.
UCAL 19.
I think it's UCAL 19 in the pediatric population.
UCAL 19.
He is not a pediatric person. He is
He's
19 years old.
19 years old. Yeah.
Oh.
So this I was teaching this to my student yesterday. These are different protocols that we use in ALL.
Mm.
For 14, 19, 60, and altogether. He can be this one as well, altogether, 0 to 29 years age, if he is pH negative. Okay. And you can offer him for 14, you can offer him for 19 as well, if he is pH negative. Why? You need to remember the names of this protocol and the age at which they can be offered to the patient. What is included inside this protocol, you are not required to remember. This will be too much.
Yeah. Can I ask Amir, from this film, sorry, you took the film out. I was just, that's fine.
You can put it again.
Just to how we differentiate, this is ALL, not AML. I mean, we know the ALL is having hand mirror, but there is no hand mirror here. So how you say this, I mean, from the film, this is ALL, not AML. It's acute leukemia, immature, but any specific feature?
I think there was few, but like not really like quite typical, but there are, I found like one or two like the hand mirror.
Mm.
First of all, you do not say on a blood film that this is AML or AL. You just say this is acute leukemia, most likely acute leukemia. We have seen many cases where we think that this is AML and the flow come out to be ALL. And many pediatric cases where we think this is ALL because of the patient age, and the flow come out to be AML or biphenotypic disease. So we do not differentiate on the basis of blood film. We just say this is acute leukemia.
Yes.
In AML, the cytoplasm will contain a lot of granules. Okay, if I can make it big. Because myeloid population usually contain granules. Okay. While in lymphoid population, in ALL, the granule, in BALL, there is no granules in the cytoplasm. The cytoplasm is usually empty. Okay. And then TALL usually come with mediastinal mass. The patient has usually a big mediastinal mass. This is one likely when you suspect that this patient may have TLL. Or secondly, they have hand mirror projections like this one. This one is a hand mirror like cytoplasmic projection because of the neighboring cells. This cell is squeezed. I'm just telling you that the hand mirror projection is like this. They have cytoplasm which has hand mirror projection or a tennis racket projection. Some people say like that. But if your patient is young, has mediastinal mass, and there are cytoplasmic projections, then you think that this may be likely TLL, but you need to confirm this on flow cytometry. If your patient does not have any mediastinal mass, but the white cell count is high and all these cells are like this with minimal cytoplasm, less granules, then you think that maybe this is BALL. But if the patient has nuclear material which is pinkish in color, this one is bluish, which is pinkish in color with prominent nucleoli, minimal cytoplasm, and we may think that maybe this is acute myeloid leukemia. But still, you will say this is acute leukemia and need to confirm this on flow cytometry. When you send your flow cytometry to diagnostic center, they give you the provisional flow report on the same day. Then you have a feeling that, okay, I'm dealing with AML or I'm dealing with ALL. Okay.
Thank you. Thank you very much.
Sorry,
We
Amir,
have
just a quick question. Is that okay? The same case?
Mhm.
Yeah, just in terms of the intracranial bleed, that you said like it is probably because of bowel brand. In terms of the management, do we, besides the neurosurgeon involvement, do we need like to say we check for the levels, or there is anything from hematology perspective to be done for the bleeding and the bowel brand, or just like it would be like the cyto reduction and this is the main thing, treating the underlying cause, no specific
no
bowel brand.
no reduction. You will do leukapheresis in this patient.
Yes,
Patient
you
with a
can.
white cell count of 700 or 800 having intracranial bleed, you would do leukapheresis to reduce
First.
the
Yeah.
cell count to double figure. Usually with one cycle, all the counts will come down to
Yes.
double figure. Okay, and once the white cell count is um, reduced, then there will be no deficiency of monolebrand in this patient.
Yeah.
But because this patient has intracranial bleed, you will top up the patient with platelet transfusion to make it above 100.
Sure.
You will see what is the fibrinogen count in this patient. If it is less than 2, according to our trust protocol, then you will give this patient fibrinogen concentrate or pyropokilocytosis. Some
Yeah.
trust says less than 1, some says less than 1.5.
Yeah. Perfect.
So you will
Okay.
top up the patient with blood product,
Yeah.
with fibrinogen concentrate, because as one of the colleagues says, this patient can have DIC as well.
Yeah.
That's why there is coagulopathy. You will address accordingly. In DIC, we keep the platelet count above 50, but here
Course.
this patient has intracranial bleed. It should be above 100. We keep the fibrinogen count about 2. Some trust says about 1.5. If you have cryoprecipitate, give cryoprecipitate. If
Yeah.
you have fibrinogen concentrate, give fibrinogen.
Perfect. Thank you.
Then this is a 50-year-old man referred to hematology because of lymphadenopathy. This is the blood test. Forward 10 and forward 15.
There's a clear cleft in that cell. Nucleoli is prominent. Probably follicular lymphoma.
I think the trainees will be very happy in your hospital.
Well,
You're making
yeah,
their
I'm an old
tranquility.
man now. A bit of experience. Platelet count looks okay. Yeah. Reds look okay. Yes, the prominence is the follicular.
Right. So let's see what our hematologist says. So who want to report this blood film? Be quick. Let's pick here someone. Taimur Hussain. And Fatima Shakar.
Yeah,
Yes, please report the blood then.
so the blood film is showing population of mature lymphocytes, small to medium size, with clefted nucleus. You can also see anemia and mild thrombocytopenia.
Hmm?
Yeah, anemia and mild thrombocytopenia.
And what is your impression?
So my impression here will be likely feature suggestive of LPD, likely follicular lymphoma. We will need to send immunophenotyping and do further testing.
So one of your colleague is asking you why you say this is follicular lymphoma. Are there any features that you think is specific for follicular lymphoma?
I can also notice here in this field there is somehow jolly bodies. Yeah, regarding the features of follicular lymphoma, the appearance of the nucleus, it appears like clefted. I think they call it a bean-shaped nucleus.
I'll go to power 100.
Yeah, there is clear cleft here.
This is the cleft. Oh, this is the cleft that is present in the follicular lymphoma cell. And these cells are small to medium. Some cells are of RBC size. Some cells are bigger than RBC.
Yeah.
Okay, what is the expected flow cytometry?
So I think it will be CD5 negative, CD10 positive, lymphocytosis, and BCL. Yeah, and then we will send for the BCL6.
What else will be positive or negative in terms of flow marker?
So flow CD5 negative, 10 positive, and then B markers CD20, 19, 20, 22, 75, 79B should be positive.
What is the expected cytogenetics in this patient?
PCL6
1418.
Mean
yeah,
translocation?
14, 1418 translocation, 1418.
1418. Oh. And what are the indications of treatment in this patient?
So patient presented with lymphadenopathy. So there will be if there is if this lymph nodes is causing compression to any of the vital structures, that will be an indication. If they have cytopenias, that will also be an indication. Yeah, and
Gulf criteria, we
and
can say.
yeah, I think it will be the staging of the patient itself, whether it's if it's advanced stage 3 to 4 on Ann Arbor's staging.
Okay. So Gulf criteria. Read the Gulf criteria for the indication of treatment in follicular lymphoma. Let's say this is an advanced stage disease. What are the options of chemotherapy with you?
Yeah, so we need an MD approach for the case. We need to check the patient functional status, comorbidities, current medications, and drug history. And then the chemo regimes will be either RCHOP or RCVP after assessing their cardiac function, or R-Benda will be also an option here.
The chemotherapy are either rituximab based or obinutuzumab based.
Okay.
They can be either R-Benda or CVP or R-CHOP. Usually patient goes with R-Benda according to my trust protocol, because if these patients relapse in the future and they convert into DLBCL, we will have a top option available. Yeah. Okay. So this was the last case.
One question, sir, for stage 4, 3 and 4 follicular lymphoma with negative JELF criteria, still we need to treat or no?
If there is no indication, that we don't.
Even if it is stage 3 and 4?
Even if it is stage 3.
Okay, thank you, sir.
If it is a single big lump, for example, a big lump here, it is compromising your vasculature, then we would treat. If it is stage 4 disease, but it is not causing any problem to the patient, no constitutional symptoms, no cytopenia, no massive splenomegaly, no massive lymphadenopathy, it does not complete the criteria of the GERD, then we just watch and wait.
هو بتمكن ممكن تاخد نص هنا.
Yeah. Go on.
Dr. Amir, what about the maintenance therapy?
Yes, you have to give the maintenance therapy after the first line chemotherapy is given. The maintenance therapy for 2 years, 3 monthly rituximab for 2 years. You have to give after first line. Okay.
Okay, thank you.
Anyone want to say anything? No? Then enjoy. Next Sunday we will have part 1, part 2 related session. If you are registered, then see you next Sunday. Thank you.
Thank you, doctor. Thank you.
Thank you so much.
Thank you.